Welcome back to the Radong Smart Review GI Cancer series.
Great to be back.
So we're picking up right where we left off, building on that foundational discussion of anal cancer.
Exactly. Last time, we really dug into why. Why definitive concurrent chemoradiation is, the gold standard.
Right, the whole sphincter-sparing approach, all thanks to Dr. Nigro's work and those big trials, ACT I, the EORTC trial, we really established the rationale.
Yeah, the groundwork. And today, we're shifting gears a bit, moving from the why to the really critical how.
How to actually do it optimally.
Precisely. It's not just following a recipe. It's about understanding how to really fine-tune modern concurrent chemoradiation for squamous cell carcinoma of the anal canal.
Okay.
And that means, really looking closely at the three absolutely critical components. You've got to have the right chemotherapy, you need the right radiation dose, the precise dose,
right,
and maybe overlooked sometimes, the right timing. Flawless timing. Get any one of those wrong, well, it can really mess things up.
Oh.
You could jeopardize the cure rates, obviously, but just as important, you could inflict unnecessary, avoidable toxicity on patients. It's really a balance, an art and a science.
Definitely sounds like it. So to keep us grounded, let's bring back our patient case from last time. Miss Jenkins.
Ah, yes, Miss Jenkins.
64-year-old woman. She has a clinical T2N1, a squamous cell carcinoma of the anal canal. Primary tumor is 4 centimeters.
Okay, so upper end of T2.
Exactly. And she has that confirmed 1.5 centimeter right inguinal lymph node. So we've decided definitive chemoradiation is the way to go for her.
Right.
But now the challenge is designing her optimal regimen. So as we, unpack the evidence today, we'll keep circling back to Mrs. Jenkins. How does this apply to her?
That's the perfect way to frame it, because as we walk through the evidence, the big trials, the latest guidelines, you should really keep Mrs. Jenkins in mind. We need answers for her.
Like what?
Well, first, what's the absolute best chemotherapy agent to pair with her radiation? We'll get into that debate. Then, what's the precise risk-adapted radiation dose? Not just any dose, but the right one for her 4-centimeter T2 tumor.
Right.
That involved inguinal node.
Got it.
And then, maybe most critically in practice, how vital is it that she completes her entire treatment course without any interruption, even a few days? We'll break down the evidence for each of these pillars.
Okay, let's do it. Let's unpack this, starting with maybe the most fundamental question, the one that's driven a lot of research and, honestly, some debate over the years.
Which is?
Mitomycin C versus Cisplatin for concurrent chemo.
Ah, the classic head-to-head.
We know the original Nigro protocol, the one that really pioneered this whole concurrent approach, used 5-FU and Mitomycin C, MMC.
That's the one.
Yeah.
Foundational.
But MMC has that well-known issue, right? The potential for significant myelosuppression. That can be really tough on patients.
That's a huge point. Myelosuppression, for anyone less familiar, we're talking about severe bone marrow suppression.
Right. Low counts.
Yeah, exactly. Dramatically lower white blood cells, especially neutrophils. That leaves patients wide open to potentially life-threatening infections.
Hospitalizations, antibiotic.
All of it. Broad-spectrum antibiotics. Sometimes growth factor support, like GCSF. Plus, you can get severe anemia, needing transfusions, low platelets, increasing bleeding risk. It's not just challenging.
No.
It can fundamentally stop a patient from staying on schedule. It impacts their safety.
Yeah.
So naturally, that toxicity profile made people wonder, could Cisplatin, which is often seen as less tough on the bone marrow,
Less hematologically toxic, yeah.
could it be a safer but equally effective substitute? And that question was really at the heart of 2 major cooperative group trials, which, interestingly, initially seemed to give us conflicting results.
Okay, so let's start with the first one, the one that probably had the biggest initial impact.
Right. That would have to be RTOG 9811.
Yeah.
Published back in 2008. Big study. 644 patients. And importantly, they focused on T2 to T4 anal cancer, so generally larger, more advanced primary tumors.
Okay.
They randomized patients into 2 pretty different arms. Arm A was the control, the standard at the time. Definitive radiation with concurrent 5-FU and Mitomycin C.
And the specifics of that regimen.
Standard stuff. 5-FU at 1,000 milligrams per meter squared per day. Continuous infusion over 96 hours.
4 days.
Yeah, 4 days. Given during week 1 and week 5 of radiation. And the Mitomycin C was 10 milligrams per meter squared IV bolus on day 1 and day 29. That was the MMC arm.
Okay, standard Nigro, basically.
Yeah.
Arm B, the cisplatin arm.
Arm B got radiation with concurrent 5-FU and cisplatin.
Okay.
The 5-FU was similar, same dose, same schedule, weeks 1 and 5. Cisplatin was given at 75 milligrams per meter squared on day 1 and day 29.
Okay, 75.
Wait, let me check that dose. Actually, apologies. The cisplatin dose in 9811 was 100 milligrams per meter squared on day 1 and day 29. The 5-FU was indeed 1,000 milligrams per meter squared over 4 days in weeks 1 and 5.
100 milligrams per meter squared. Okay.
Yes. Now, here's the kicker. The really crucial part for interpreting this whole thing.
What's that?
The cisplatin arm also received 2 cycles of induction chemotherapy before starting their concurrent chemoradiation.
Induction chemo. With what agents?
Typically 5-FU and cisplatin, the same agents they'd get concurrently, but given up front.
So hold on. That induction chemo in the cisplatin arm, that's a major confounder, isn't it?
Huge. Absolutely massive.
It delayed the start of their radiation?
By definition, 2 cycles of induction chemo meant, several weeks delay before those patients even started their main concurrent treatment.
Okay, so that's critical context. What were the results?
The results were, well, pretty stark. The Mitomycin C arm came out superior across the board, pretty much every endpoint measured.
Like overall survival?
Significantly better. 5-year overall survival. 78% for MMC versus 71% for cisplatin. That's a 7% absolute difference.
Wow. That's substantial.
It is. Disease-free survival also clearly better. 68% for MMC versus 58% for cisplatin. 10% difference there.
And what about sphincter preservation? Colostomy rates?
Also significantly better with MMC. The 5-year colostomy rate was much lower. 10% in the MMC arm versus 19% in the cisplatin arm.
Almost double.
Almost double. So patients were far more likely to keep their sphincter, avoid a permanent colostomy, if they got the MMC regimen in this trial.
Okay, so RTOG 9811 on the surface seems to say MMC is definitively superior, but that induction chemotherapy hanged over it.
Exactly. That's the elephant in the room. Was it truly that MMC is a better radiosensitizer? Or was it the harm caused by delaying radiation with that induction chemo that made the difference?
That's a huge question. Did MMC win, or did delaying radiation lose?
Precisely. That confounder was, and still is, a major discussion point whenever 9811 comes up.
So how did the field try to answer that specific question?
Well, that led directly to the UK ACT2 trial. Remember, pronounce it like the word ACT.
ACT2, got it.
This trial was meticulously designed to eliminate that confounding induction chemotherapy. To get a clean comparison.
What, is similar in size?
Even larger, actually, 940 patients. And notably, it included anal cancer of all stages, not just the T2, T4, like 9811.
Okay, and the design?
It used a clever 2x2 factorial design, so 2 randomizations happening. The first randomization directly addressed our question. It compared chemoradiation with 5-FU/MMC versus 5-FU/cisplatin. Critically, both regimens started concurrently with radiation from day 1. No induction delay. Apples to apples on the timing.
Perfect. The second randomization we'll discuss later.
Oh, exactly. That looked at maintenance chemo. We'll get there. But for this comparison, MMC versus cisplatin given concurrently, what did ACT2 find?
What were the results of that direct comparison?
In that head-to-head, ACT2 found no significant difference.
No difference. In what?
In complete response rates, in progression-free survival, or in colostomy-free survival. The 3-year progression-free survival, for instance, was about 75% in both arms, basically equivalent efficacy.
Wow. Okay. What about toxicity? Did MMC still show more myelosuppression?
It did. The MMC arm had slightly higher rates of grade 3 or higher hematologic toxicity, about 26% versus 16% for cisplatin.
So confirming that known side effect profile.
Right. But interestingly, the overall non-hematologic toxicities were pretty similar between the 2 arms. So the main difference was really that blood count issue.
So the interpretation from ACT2 was
pretty clear. When you give them concurrently, without that induction chemo delay, cisplatin appears to be non-inferior to Mitomycin C.
Meaning equally effective.
Equally effective, just with a slightly different, potentially less hematologically toxic.
Okay. So now we have RTOG 9811 saying MMC is superior and ACT2 saying they're basically equivalent or non-inferior. How do we reconcile this? What's the practical take-home for treating Ms. Jenkins today?
This is where the clinical judgment, understanding the nuances, really comes in. The key, as you pointed out, is that induction chemotherapy in 9811.
The delay.
That delay in starting radiation for the cisplatin arm likely skewed the results. It probably disadvantaged the cisplatin arm unfairly just by starting definitive therapy later.
Right.
So while 9811 initially made it look like MMC was just flat out better, ACT2 helped us understand why that might have appeared to be the case. It helped isolate the pure chemotherapy effect from the timing effect.
Okay, so where does that leave us now? What's the consensus? Like the Astro guidelines, what did it say?
The current consensus, and this is reflected well in the 2025 Astro guidelines, is that 5-FU/MMC still remains the preferred standard of care.
Preferred. Okay. Despite ACT2.
Despite ACT2, I think that overall survival benefit seen in 9811, even with the known confounder, carries a lot of historical weight. It kind of anchors MMC as the default.
Clinical inertia, maybe, or just respecting that survival signal?
Probably a bit of both. But, crucially, the guidelines also acknowledge cisplatin as a very reasonable alternative.
For whom?
Especially for patients where that risk of myelosuppression is particularly concerning. Maybe someone with poor baseline counts, or pre-existing bone marrow issues, or maybe someone very frail.
Okay.
So, for Ms. Jenkins, if she's got good blood counts, no major contraindications, the default choice would likely still be 5-FU/MMC. We'd lean on that historical strength.
But if she did have risk factors for myelosuppression?
Then switching to concurrent cisplatin, or even capecitabine, which we'll discuss, would be a perfectly valid evidence-based chase, offering similar efficacy based on ACT2. The key is concurrent administration. No induction delays.
Makes sense. Understanding the history and the nuance behind the preferred label. Okay, let's shift gears. We've talked chemo agents. What about the radiation side? The dose.
Right. Equally critical.
The goal is always maximizing local control, killing the tumor, while minimizing late toxicity, preserving function and quality of life. That balance.
It's the perpetual challenge, isn't it? Especially in the pelvis. And the evidence here strongly points towards a risk-adapted approach. Meaning we don't just give everyone the same dose. We need to tailor it. Specifically, you need to judiciously escalate the dose for larger tumors and for any involved lymph nodes.
Why escalate for those?
Because they inherently carry a higher risk of microscopic spread, maybe more resistant cells. They just need a higher dose to ensure eradication. It's definitely not one size fits all.
And the Astro guidelines give specific recommendations here.
They do. The 2025 guidelines are quite clear, distilling data from many trials into actionable advice.
Okay, walk us through it. Let's start with smaller tumors. What's the dose range?
For clinical T1 to T2 tumors, the guideline recommends a dose of 45 to 50.4 gray.
45 to 50.4. And how many fractions?
Typically delivered in 25 to 28 fractions. This comes from seeing excellent results in those foundational trials, like RTOG 8704 and 9811, where many T2 patients were cured even with 45 gray.
So that range is kind of the sweet spot for good control, acceptable toxicity for smaller tumors.
Exactly. But there's an important caveat for larger T2 tumors.
Like Ms. Jenkins, hers is 4 centimeters.
Precisely like Ms. Jenkins. For T2 tumors that are 4 centimeters or bigger, the guidelines suggest that pushing the dose towards the higher end of that range, say 50.4 gray or maybe even up to 54 gray, might be reasonable.
And the thinking there is?
Just that a larger tumor, even if still stage T2, likely has a higher burden of disease, maybe more heterogeneity, potentially more resistant clones. It might just need that extra bit of radiation punch to ensure cure and minimize recurrence risk.
Okay, so for Ms. Jenkins, we're already thinking maybe closer to 50.4 gray for her primary, given its size.
That would be a very reasonable starting point for discussion, yes.
Now, what about the really big ones? The T3, T4 tumors, inherently tougher cases.
Right. For those, clinical T3 to T4, a significantly higher dose is recommended. We're talking 53.2 up to 59.4 gray.
53.2 to 59.4, that's quite a jump.
It is, and it's usually delivered in slightly more fractions, maybe 28 to 33. This dose escalation is critical.
Why so critical? What's the evidence?
Well, data from trials like RTOG 9811 clearly showed much higher rates of local failure and, consequently, higher colectomy rates for these larger tumors when they were treated with lower doses, like the 45 gray range.
You have an example?
Yeah, for instance, in the MMC arm of 9811, patients with T4N0 disease, they had a 5-year local renal failure rate of 37%.
Wow, 37% failure even with MMC chemo.
Yes, that's really high. It tells us loud and clear that these bigger, more advanced tumors simply need more radiation dose to achieve durable local control. We have to push that dose-response curve carefully, of course.
Carefully managing normal tissue tolerance, especially in the pelvis.
Absolutely. It's a fine line.
Okay, so that covers the primary tumor dose based on T stage. What about the lymph nodes? Mrs. Jenkins has that confirmed 1.5 centimeter inguinal node.
Right. For clinically involved nodes, like hers, palpable or seen clearly on imaging, the recommended dose is 50.4 to 54 gray.
50.4 to 54, similar to the dose for a larger primary.
Exactly. You need to adequately treat that gross disease. We wouldn't want to underdose a known involved node.
Makes sense. And what about elective nodes, the areas at risk but not obviously involved?
For those elective nodal volumes, think the other inguinal regions, the pelvic nodes like internal iliac, external iliac, obturators we treat prophylactically, but to a lower dose. Typically 36 to 45 gray.
36 to 45, and that's usually in maybe 20 to 30 fractions.
Correct. The idea is to cover those at-risk areas, sterilize potential microscopic disease, but without giving excessive dose to large volumes of normal tissue, minimizing collateral damage and long-term side effects.
Okay, so let's try a quick mnemonic here for the primary tumor doses. Maybe. 4-5 for small, 5-3 for large.
Like that, yeah.
So T1, T2, think 45 gray range up to 50.4. T3, T4, think 53 gray range up to 59.4.
4-5 for small, 5-3 for large. That's sketchy. Help simplify it. Good one.
Okay, so we've got the chemo agent choice. We've got the risk-adapted radiation dose. What about adding more chemo? Does induction chemo before or maintenance chemo after help?
The more is better question. It comes up in so many cancers.
Right. Does it apply here in anal cancer?
The answer, based on good evidence from key trials, is a pretty resounding no. And knowing this is really important.
Okay, tell us about induction first. Chemo before chemo-RT.
The French ACT-I trial tackled this head-on. They took patients with larger tumors or node-positive disease, the higher-risk groups, and randomized them.
To what?
To either get induction chemo first, typically 2 cycles of 5-FU and cisplatin, or to go straight to standard concurrent chemoradiation.
And the rationale for induction was?
The usual thinking. Shrink the tumor up front, maybe make the main treatment easier, and hit potential micrometastases early. Plausible ideas.
But what did they find?
They found absolutely no benefit. No improvement in colostomy-free survival, no improvement in progression-free survival, no improvement in any major endpoint by adding that upfront induction chemo.
No benefit at all.
None. And if anything, there was maybe a trend towards more toxicity without any gain. It just delayed the start of definitive local therapy, which, as we discussed with 9811, can be detrimental.
So induction is out. What about maintenance? Chemo after finishing chemo-RT to kind of mop up.
Again, the answer is no. And this comes from that same UK ACT2 trial we discussed earlier.
Ah, the second randomization?
Exactly. Remember the 2x2 design. After patients finished their concurrent chemoradiation, either with MMC or cisplatin, they were then randomized a second time to either receive 2 cycles of maintenance 5-FU/cisplatin or to get no further maintenance chemotherapy. Just observation.
And the result? Did the maintenance chemo help?
Nope. Just like induction, there was no benefit whatsoever. No improvement in progression-free survival, no improvement in any other oncologic outcome by adding those 2 extra cycles of chemo.
It just added toxicity.
Pretty much. Added toxicity, added burden on the patient, cost, time, all for no measurable gain in efficacy.
So the take-home message here seems crystal clear for anal cancer.
It really is. The chemotherapy needs to be given concurrently with the radiation. That's where the magic happens.
The synergy, the radiosensitization.
Absolutely. That's what drives the high cure rates and allows for sphincter preservation. Adding chemo before or after that concurrent window just doesn't seem to add value in this disease.
Okay. That's a really important principle to grasp.
It is. And it leads us directly into the next point, which is, honestly, maybe one of the most critical practical pearls in treating anal cancer day to day.
What's that?
The absolute criticality of avoiding treatment breaks. We have to emphasize this. It's not a minor detail. It can literally determine whether the treatment works or not.
Wow. Okay. Avoiding breaks. Why is it so important? What's the evidence?
There's really strong evidence. A key piece is a pooled analysis by Ben Joseph, published back in 2010.
What did they pool?
Data from 2 of those big RTOG trials, 8704 and 9811. They look specifically at the total treatment duration, from day 1 of radiation to the last day.
And what did they find?
It's something quite alarming, actually. They found that if the total treatment duration stretched beyond 53 days...
53 days, how long is that typically?
Well, a standard course is around 6 weeks, maybe 6.5 with common fractionation. So 53 days is roughly equivalent to having about a 1-week interruption, maybe a bit more, baked into the total time.
Okay. So if the treatment drags out by about a week or more.
It was significantly associated with worse local regional failure, meaning the cancer was more likely to come back in the treated area and worse failure-free survival overall.
Just from a 1-week delay, that's a huge impact.
It is. The thinking, the biological rationale is likely accelerated tumor repopulation.
Meaning the cancer cells start growing back during the break.
Exactly. Radiation stuns them, damages them, but if you give them a break, the surviving cells can recover, start dividing rapidly again, potentially even faster than before.
Yeah.
You basically lose ground.
Undoing some of the work the radiation did.
Precisely.
That's a powerful reason to avoid breaks. What about studies that actually planned for breaks? Maybe thinking it would help with toxicity.
Well, that provides an even starker lesson, unfortunately. Look at the RTOG 9208 trial. This was a dose escalation study,
Okay.
and they actually included a planned 2-week treatment break in their protocol design. The hypothesis was maybe this split course would allow normal tissues to recover, reduce toxicity without hurting efficacy.
Sounds reasonable on the surface. What happened?
The result, particularly for organ preservation, was disastrous. They saw a much higher colostomy rate compared to the historical controls from RTOG 8704, which used continuous treatment.
How much higher?
It jumped from about 6% in 8704 to 23% at 1 year in 9208.
23%. That's almost a 4-fold increase in needing a colostomy.
Exactly.
Mm-hmm.
It was a dramatic demonstration of the direct, detrimental effect of treatment interruptions on both tumor control and the patient's quality of life, specifically sphincter preservation.
So for Ms. Jenkins, this means we have to do everything possible to prevent any breaks.
Pull out all the stops. Proactive management is key.
And this evidence is so strong that the ASTRO guidelines now formally address it, right?
They do. The 2025 guideline makes a conditional recommendation.
Conditional.
Yeah, meaning the evidence is strong, but maybe not from multiple large randomized trials directly testing breaks versus no breaks. But based on the available data, they conditionally recommend that the overall chemoradiation treatment time should not be extended by more than 4 days.
Not more than 4 days. That's a very tight window.
It is. It underscores how important it is for improving progression-free survival. It gives us a very concrete target. Extending beyond that short buffer is associated with worse outcomes.
Which means, practically speaking, proactive toxicity management isn't just nice to have, it's absolutely paramount.
It's essential. You can't wait for problems to happen. You need to anticipate them. Skin care, pain management, diarrhea management, nutritional support. Start it all early. Counsel the patient on the importance.
Be aggressive with supportive care to keep them on track.
That's the only way.
Okay, super important point. Now, let's quickly review the standard concurrent chemotherapy regimens and the specific dosing. People need to know these cold.
Absolutely. Let's start with the classic, the Nigro regimen. 5-FU and Mitomycin C.
Okay, the doses?
5-FU is 1,000 milligrams per meter squared per day. That's given as a continuous infusion over 96 hours.
4 full days.
4 days. And that's typically given during week 1 and then repeated during week 5 of the radiation therapy.
Weeks 1 and 5, got it. MMC.
Mitomycin C is 10 milligrams per meter squared, given as an IV bolus on day 1 and then again on day 29.
Day 1 and day 29, so near the start of each of those 4-day 5-FU infusions.
Generally, yes. Now, it's worth noting, the ACT II trial actually used a slightly different MMC schedule, a single dose of 12 milligrams per meter squared, just on day 1.
Ah, okay. Single dose versus 2 doses.
Right. But I'd say the 2-dose approach, 10 milligrams per meter squared on day 1 and day 29, is probably more common in U.S. practice, reflecting the original RTOG protocol.
Okay, so that's the standard Nigro. 5-FU infusion weeks 1 and 5, MMC bolus days 1 and 29. Are there common alternatives, especially if the infusion is difficult for a patient?
Yes, definitely. The main alternative involves switching out the infusional 5-FU for its oral prodrug, capecitabine.
Capecitabine or Zlota.
Right. So the regimen becomes capecitabine plus Mitomycin C.
And the capecitabine dosing?
It's typically 825 milligrams per meter squared, taken orally twice a day.
825 BID.
But here's the critical part. It's taken only on the days the patient receives radiation treatment. not on weekends or breaks.
Ah, only on RT treatment days. That's important.
Very important. It's a huge convenience factor, obviously.
Mm.
Avoids the infusion pump, central line access, maybe daily clinic visits for the infusion.
Much easier logistically for many patients.
Absolutely. And the Mitomycin C is dosed the same way as with infusional 5-FU, either the single dose or the 2-dose schedule.
And is this considered equivalent? What do the guidelines say?
The ASTRO guideline strongly recommends capecitabine as a reasonable alternative to infusional 5-FU. The evidence suggests similar efficacy, and it offers that flexibility and convenience. So yes, widely accepted.
Great. Good to have that option. Okay, so we've systematically gone through the evidence. We've dug into the trials, clarified chemo choices, radiation dose principles, the role or lack thereof of induction maintenance, and the absolute criticality of avoiding breaks.
Covered a lot of ground.
Now let's bring it all together. Back to Ms. Jenkins. Clinical T2N1A, 4 centimeter primary, 1.5 centimeter inguinal node. Let's make some evidence-based decisions for her plan.
Okay, let's design her optimal regimen, starting with chemotherapy choice,
What's the call for her?
based on everything we discussed. Assuming she has good baseline blood counts, no specific contraindications like severe kidney issues for cisplatin or marrow problems, the standard of care, the preferred choice would be concurrent 5-FU and Mitomycin C.
Okay, sticking with the preferred standard.
Right. While ACT2 showed non-inferiority for cisplatin, that overall survival signal from 9811, even with the confounder, still kind of anchors MMC as the go-to for many centers. Clinical comfort, historical weight.
But we keep the alternative in mind if needed.
Absolutely. If she had risks for myelosuppression, concurrent cisplatin or concurrent capecitabine MMC would be very reasonable, equally effective options based on ACT2. But for a standard case like hers appears, start with 5-FU MMC.
Okay. Decision 1, likely 5-FU MMC. Now, radiation dose, 4 centimeter T2 primary, involved inguinal node. What's the prescription?
All right, for her primary tumor, it's a T2, but it's 4 centimeters. So as per the ASTRO guidelines, the range is 45 to 50.4 gray. But given it's at that upper end of T2 size, potentially behaving more like a T3, pushing the dose towards the higher end of that range makes sense. Something like 50.4 gray and 28 fractions seems very appropriate for the primary.
50.4 gray and 28 fractions to the primary.
Okay.
And the involved node.
For her clinically involved 1.5 centimeter inguinal node, a dose of 50.4 gray is also perfectly appropriate. Maybe even up to 54 gray could be considered for gross disease, but 50.4 is certainly well within the recommended range of 50.454 Guy.
Okay, 50.4 to the node as well. And elective nodes.
Elective nodes to the pelvis, bilateral groins not grossly involved would get that lower prophylactic dose, typically 45 gray in 25 or 28 fractions, or maybe even down to 36 Gs depending on the exact volumes and philosophy. Let's say 45 gray for standard coverage.
Got it. So primary and involved node boosted to 50.4 Guy, elective nodes to 45 Guy.
That's a very standard evidence-based approach for her stage.
And finally, maybe the most critical piece of the discussion with her, treatment timing.
Paramount. Absolutely paramount for Mrs. Jenkins.
Yeah.
We need to sit down with her, maybe even multiple times, and really emphasize how crucial it is to complete all 28 radiation treatments and the chemo cycles without interruption, if at all possible.
Set expectations about side effects, but also about the importance of pushing through.
Exactly, and back that up with aggressive, proactive toxicity management from day one. Skin creams, pain meds, antidiarrheals, nutritional counseling, maybe even prophylactic antibiotics if needed for skin breakdown. Don't wait for problems.
Because, as we saw, even a few days' delay can impact her chances of cure, her chances of keeping her sphincter.
Precisely. It affects progression-free survival, colostomy-free survival, local control. It's a team effort between us and the patient to stay on track for those 6 weeks.
Okay. That feels like a solid, personalized, evidence-based plan for Ms. Jenkins.
I think so. It addresses all the key components.
All right, great discussion. Let's pivot now to some clinical pearls. These are the absolute highest yield facts, the things you really need to lock in for exams, for boards, and just for safe, effective practice. The sticky knowledge.
Okay, let's crystallize them. Pearl number 1, MMC versus cisplatin. What's the bottom line?
RTOG 9811 showed superior overall survival and disease-free survival for 5-FU-MMC over 5-FU cisplatin. But that was confounded by induction chemo in the cisplatin arm?
Right, and ACT2 without induction showed non-inferiority. So, the takeaway. 5-FU-MMC remains the preferred standard, largely due to that historical OS benefit, but concurrent cisplatin or capecitabine MMC is a reasonable alternative, especially if myelosuppression is a major concern.
Pearl number 2, radiation therapy dose by T-stage. Use our mnemonic.
4-5 for small, 5-3 for large. T1, T2 tumors generally get 45 to 50.4 gray, but for larger T2s, like 4 centimeters or more, and certainly for T3, T4 tumors, you must dose escalate. Up to 59.4 gray is recommended in the guidelines for T3, T4. Dose adapt.
Pearl number 3, no induction or maintenance chemotherapy.
Absolutely critical. ACT-03 showed no benefit for induction. ACT2, second randomization, showed no benefit for maintenance. The chemo must be given concurrently with radiation for that synergistic effect. Don't add extra chemo before or after. It doesn't help and just adds toxicity.
Pearl number 4, avoid treatment breaks. This one is huge practically.
Cannot emphasize this enough. Extending the overall treatment time by more than about 4 days is strongly associated with worse local control and worse progression-free survival, likely due to tumor repopulation. Proactive toxicity management is key to keeping patients on schedule and preserving outcomes, including sphincter function.
Pearl number 5, know your standard chemo dosing.
Classic Nigro. 5-FU 1,000 milligrams per meter squared per day for 4 days, continuous infusion weeks 1 and 5, Mitomycin C 10 milligrams per meter squared IV bolus days 1 and 29,
And the alternative?
capecitabine 825 milligrams per meter squared orally twice a day, only on radiation therapy days, with MMC dosed as above. A very reasonable and convenient alternative. Know both options.
Excellent pearls. Now, let's briefly touch on controversies and advances. Sometimes what seems like a controversy gets settled by trials, and that itself is an advance, right? It clarifies our approach.
That's a great way to put it. The whole MMC versus cisplatin debate is a perfect example.
Yeah.
The conflicting initial results from 9811 and ACT2 created a lot of discussion, maybe even controversy.
Right.
But understanding the confounder, the induction chemo delay, helps reconcile them. It didn't necessarily lead to one simple answer, but rather to a more nuanced understanding.
How so?
Well, MMC remains preferred, influenced by that historical OS signal, but cisplatin gained ground as a clearly viable, non-inferior alternative when given concurrently, especially for certain patients. So the advance wasn't picking a single winner, but rather validating a good alternative, allowing for more personalized, risk-adapted chemo choices. That's progress.
And similarly, the questions around induction and maintenance chemo were effectively settled controversies, right?
Absolutely. Before ACCORD03 and ACT2, it was a legitimate question, would more chemo help? These trials provided definitive negative answers for anal cancer.
So the advance was?
The advance was streamlining treatment, proving that adding chemo outside the concurrent window was unnecessary, avoided extra toxicity, cost, and patient burden. It solidified the paradigm of concurrent therapy as the essential component. That clarification is an advance in defining optimal, efficient care.
It helps us focus our efforts where they actually make a difference.
Precisely. It's about ensuring every part of the treatment plan adds real value. Looking forward, areas like optimizing treatment for elderly frail patients, refining response assessment with PT scans, maybe de-intensification for excellent responders,
Okay.
those are areas of ongoing evolution.
Always more to learn. Okay, you ready for a quick board blitz?
Let's do it. Test the knowledge.
Case 1. 55-year-old man, T3N0 anal cancer. Primary tumor is 6 centimeters. He's planned for definitive chemoradiation. According to the 2025 ASTRO guidelines, what's the most appropriate radiation dose to the primary tumor? A, 45 gray and 25 fractions. B, 50.4 gray and 28 fractions. C, 54 gray and 30 fractions. D, 66 gray and 33 fractions.
Okay. T3, 6 centimeters. That's definitely the large category. So A and B, the 45 and 50.4 GR ranges, are generated for T1, T2 tumors, so they're too low. D, 66 DR is quite high, not standard, and likely too toxic without proven benefit. C, 54 gray in 30 fractions, falls right in that recommended range for T3, T4 tumors, which is 50.2 to 59.4 gray. So C is the best answer. Needed dose to escalate for this T3 tumor.
Excellent reasoning. C it is. Case 2. Patient being treated per the ACT2 protocol asks why they aren't getting more chemo after radiation finishes. What's the correct explanation? A, maintenance chemotherapy was found to be too toxic. B, maintenance chemotherapy was found to provide no benefit in progression-free survival. C, maintenance chemotherapy is only for patients with an incomplete response. D, the trial is still pending and results are not yet known.
Okay, this relates directly to that second randomization in ACE2. The trial is complete and published. Maintenance chemo isn't standard only for incomplete responders. While toxicity is always a factor, the primary finding was the lack of benefit. So B is the best answer. The ACT II trial clearly showed no improvement in progression-free survival or any other outcome by adding maintenance 5-cisplatin. It simply didn't work.
Perfect. Answer is B, case 3. Patient on treatment develops severe perineal dermatitis, really bad skin reaction, and asks for a 1-week treatment break to heal. What's the most important reason to counsel against this break? A, it will increase the risk of late rectal bleeding. B, it will make the concurrent chemotherapy less effective. C, it is associated with a higher risk of local regional failure and worse progression-free survival. D, it will increase the final colostomy rate due to surgical complications.
Tough situation clinically, but the evidence is clear. While breaks might indirectly affect other things, the most critical evidence-based reason to push against that break is C. The pooled analyses, the RTOG-9208 experience, the STO guideline, they all point to treatment prolongation being strongly associated with worse local control and worse progression-free survival, likely due to that accelerated tumor repopulation. That's the biggest hit to their oncologic outcome. We need to manage the dermatitis aggressively without stopping treatment if at all possible.
Exactly. C is the most critical oncologic reason. Fantastic. Okay, let's summarize. Today, we really dove deep into optimizing standard chemoradiation for anal cancer. We've looked at the evidence to define the best chemo agent, how to pick the right radiation dose based on risk factors like T-stage and nodes, and we've really hammered home the importance of timely completion.
Yeah, for our patient, Ms. Jenkins, we now have a much clearer picture of her optimal plan. We dissected the evidence from key trials 9811, ACT2, ACCRT 03, and integrated the latest ASTRO guidelines. We know 5-FU-MC is preferred, but cisplatin is a good alternative. We know dose needs to be risk-adapted, up to 59.4 Weilogi for T3, T4.
And critically, we cemented that neither induction nor maintenance chemo adds value. It has to be concurrent. And finally, avoiding treatment breaks is absolutely paramount for preserving local control, survival, and sphincter function. Proactive supportive care is non-negotiable.
Couldn't have said it better. And translating this plan, this prescription, into a safe and effective IMRT plan is the next logical step. So, looking ahead, our next session will be an IMRT treatment planning workshop specifically for anal cancer.
Ooh, sounds practical.
Yeah, we'll do a step-by-step guide. Simulation, contouring, dose painting, drawing heavily on protocols like RTOG 0529, and incorporating these new ASTRO guideline principles we discussed today. We'll show you exactly how to put this into practice in the planning system.
That sounds incredibly valuable. Remember, you can sharpen your skills with practice oral boards and explore more content at radonkSmartLearn.com. That's RADONK smartlearn.com. And definitely subscribe to Radonk Smart Review so you don't miss that IMRT planning workshop.
Thanks for tuning in, everyone.
See you next time.